like to welcome you to the AO Trauma North America Fellows webinar. Tonight we'll be discussing pelvic fractures, specifically really focusing on the posterior aspect of the pelvis, looking at the SI joint, as well as sacral fractures. Going to go over some approaches, reduction aids, and then fixation strategies. I'm going to be moderating the session. I will also briefly go over some reduction aids and a case looking at an SI joint injury. We have two esteemed faculty that are joining us today, Dr. Adams from Rutgers Medical School in New Jersey and Dr. Eastman from Houston at McGovern Medical School. Thanks a lot, guys, for joining on.
Thanks for having me.
Just some housekeeping stuff to go over in terms of content validation. You can go ahead and read those 3 points briefly. Really, the overview and the purpose of this is that pelvic ring injuries can be treated in a number of different ways. And there's simple fractures, there's complex fractures, and while there's no one right way, there are ways to thinking about them when you're trying to sort things out. And we really want to tonight focus on the posterior ring. However, we can't ignore the anterior ring injury. A lot of times the decisions we make in regards to the posterior ring relate to what the anterior ring injury looks like. So we're going to discuss that a little bit through the case-based discussions, and that's how the night will be planned in terms of that. There's a number of learning objectives, which you've all seen from the pre-meeting notes. So the agenda really will be, we'll first look at SI joint reduction strategies. Then Dr. Adams is a really neat talk where he's going to talk about indications for different posterior approaches and bring up something that's really interesting that we don't talk that much about in regards to angiosomes and how angiosomes may affect what we do in the back. You may have heard trauma surgeons talking about angiosomes around the ankle, but here you're going to hear about it in regards to the posterior aspect of the pelvis. And then Dr. Eastman's got some phenomenal cases where he's going to discuss some different reduction techniques that can be utilized for sacral fractures. And then if time allows at the end, we got 1 or 2 cases to go over at the end and answer some questions. So again, we would love to thank the AO North America Trauma folks. These are a series of webinars, the next of which I believe is on March 11th, looking at acetabular fractures in the elderly patient population. And also there's the AO trauma webinars. The next one is January 21st, 2025, looking at the hip. So I'm going to first start with looking at SI joint injuries and reductions, and we'll go over a case. These are my disclosures, none of which pertain to what I will be speaking about tonight. So let's start with this. 32-year-old male, status post fall from a significant height. As you can see here, the left hemipelvis is vertically displaced. He's got superior and inferior pubic rami fractures. I don't have detailed cuts of the CT pulled up, but I'll just say that it's a relatively simple anterior ring injury and a complete disruption of the left sacroiliac joint. Now, Mark or John, when you look at this, like, is this something where you're like, okay, he's young, he's 32, let's pretend he's healthy, doesn't do drugs, he doesn't have psych issues, relatively normal 32-year-old male. You know, are you going to try a closed reduction with this? How eager are you to do an open reduction of that side joint? He's not obese. Are you going to try to assess the front and potentially approach the front, being that I already told you it's a relatively easy reduction? To help you with the back, do you think that really helps? Just some points to discuss in terms of when you look at this, what would you do?
So at first glance, I'm very eager to do an open reduction for this. I'll say probably maybe something you've encountered too is the problem is sometimes you start doing a closed reduction maneuver and things start looking pretty good, and then you're in this quandary about we're pretty darn close here with the reduction now. Yeah, with a much better reduction than this. Now, do I need to still open the patient? And if you have say a 3D C arm and things like that, then you can really critically evaluate it very well and to know whether or not you really do have an accurate reduction at that point.
Now, Mark, when you mean an open reduction, are you talking about an open reduction of the front, open reduction of back, or both? And
Oh,
if you're going to do that, which one would you go to first?
sorry. Yeah, I mean, my eyes, for the back, I'm talking about the back with the eagerness for the open reduction is the lateral window, an extended
Yeah.
version of the lateral window. With this ramus fracture, you have the nice thing is that supine, you have the option of doing an open reduction, but it doesn't necessitate it. We know how to do percutaneous methods to improve this reduction quite a bit, perhaps get it quite close. And so we have both options in the front as well.
Okay. John, what about you? What do you think?
Yeah, Reza, I mean, I think if you move that injury anteriorly, just 3 centimeters towards the midline and it's a symphyseal disruption, I don't think many people are not going to start to try to do an open reduction of the symphysis first to kind of reestablish that hinge and do some sort of indirect reduction that may or may not help you all the way posteriorly. That leads to some of what Mark was said in terms of percutaneous options for reductions and so forth. And so I think a lot of the times, if the anterior ring is truly reconstructible, and I think we may get into that with different examples, but I think I often lean towards doing that just for the same reason of can I get an intact hinge that can help me take some plane of instability off the board, and then I'm dealing with maybe a more simple injury than we currently have. I think you have multiplanar instability, and that's a lot to try to do percutaneously without some sort of heavy manipulation to try to get some sort of reduction back. And so I think the anterior ring, if it's there and it's truly reconstructible, fairly straightforward. I think I'll often try.
So if I take what both of you have said from a teaching point, if you have an anterior ring injury and it's a simple injury and you're confident that you're going to be able to anatomically reduce that injury, then you would approach the front, reduce it, clamp it, potentially fix it, or just reduce it and clamp it. And by doing that, you're going to facilitate your reduction of the back because if you have this floating hemipelvis out there and you try to open reduce the back up front, we all know that reduction is not as easy as it sounds in the back. And sometimes rotationally things can be off. Sometimes there's overriding osteophytes that can make it challenging. And I have a hard time. We can all close that down, and I think we can bring this pelvis down. But I think the hard part is getting that thing rotationally right, looking at the read in the back. And if we get the front right, I think that would help with some of that rotation. Is that kind of what you guys are getting at too?
100%. And so I love improving, say, the front. Exactly. So this injury here, say we were able to reduce that superior pubic ramus. That's going to help us quite a bit in the back. And the issue is though that it is by definition not anatomically reduced until the back is reduced and that inferior ramus is reduced. And it may look reduced but you're only, if you think of this entire injury, that ramus is like 5 to 10% of it, what that read. And so it may key in, but there's something slightly off about it. But it's still a heck of a lot better than it is now, and it's going to help us a lot with what's going on in the back.
Great. That's a great point, Mark. Now, let's say that this was a morbidly obese patient with a BMI of, let's say, 50 or 45. Okay. So, obese patient. How confident are you in an obese versus non-obese patient when you open reduce the back? Do you lean away? I'm not even talking about the complications associated with an open reduction and increased risk of potential infection, but I'm talking about your confidence of seeing that SI joint and being able to reduce in somebody that's obese.
Yeah, it's
Go ahead, Mark.
no, yeah, no, it's it's one of those situations where it's very worrisome until you finally have made progress. And there's a potential where you're still, even when you make progress, you still may be struggling quite a bit. So I don't have a cookbook answer for that.
So just be maybe in that situation, be ready and anticipate that it is going to be a lot harder to do in an obese patient in terms of visualizing things and getting that reduction right. And maybe not be as eager in somebody who's so obese. Maybe try some other methods. Mark, you mentioned, I think, try to get potentially, closed reduction. You can always, if you have a 3D, um, if you have a 3D means of getting intraoperative CT scan, then you can assess your reduction before you decide to open it in somebody that's got some challenges such as being obese. Well, that was great, and we'll go over that case in a second in terms of what was done. Just briefly, and I think a lot of you have seen this, but I think it's important to review it. Routinely, I'm doing these in a supine position. I think it's extremely important to drape in the leg so you can flex the hip and knee. That'll get you a lot more exposure by relaxing the iliopsoas. I like to work from the ASIS posteriorly because that's the easiest to palpate. You want to take off the external oblique off its insertion off the crest. Proximally, you're going to get into the external oblique muscle. You want to split that in line with the muscle fibers and then really perform a subperiosteal dissection along the inner table. And when you're first starting out, especially since a lot of you are fellows, you can get lost, especially in somebody who's bigger. And don't hesitate if you don't know where the anterior aspect of that side joint is. Don't hesitate to put your Freer or Cobb there and shoot an X-ray and kind of see where you are before you're dissecting way too medial and injuring the L5 nerve root or going way too posterior. So, use some of these other means in terms of really telling you where you are. Anything to add to that in terms of just positioning and approach, John or Mark?
Yeah, I think one question that always kind of comes up is people, they have a preference or they're unsure of, do I need some sort of extension like an ASIS osteotomy or a release of the ligament? What do you guys think?
Go ahead, Mark.
I do routinely extend it to fully mobilize the iliacus and so forth. I think both are very good ways to go about it. And I tend to do the lateral half of the middle window as my go-to, but the ASIS osteotomy is a very good way of doing it.
I would agree with Mark. I do it similarly there in terms of taking off the inguinal ligament, doing a peel. I have done the SS osteotomy, um, and just based on what I did early on in my practice, I continue to peel the ligament and not necessarily do the osteotomy, but I think it's fine to do both. I don't do it routinely though. Only if I can't see and I really feel like I'm stretching things out, do I do it. And that again tends to be in the more obese patients where I think I need to do something like that.
Okay.
So let's jump into reduction instruments for the SI joint. I think these are the workhorse instruments. The Faribuff bone holding clamps, the Jungbluth clamp I find extremely helpful. I also think the Goose clamp is really helpful. I like having 5mm Chance pins as joysticks to control the hemipelvis. So one 5mm Chance pin down the gluteus medius pillar, another 5mm Chance pin in the anterior inferior iliac spine, and hooking up chucks to those, and then using those to kind of manipulate the hemipelvis to kind of get it to where I want to place it. And a lot of times, one clamp may not work, and you may be struggling. Well, try something different, and I've had that happen. And in the case I'll show you, you'll see that. But you should be familiar with all these, and you should know how to use these because they can be useful. Here's just an example of the Faribuff clamp. Routinely, you're putting 2, 3, 5 screws. Now, the bone in the sacrum is not going to be great bone. If you're, shooting into the ala, I try to skive right by the SI joint. The blue markers I have there are really the 5mm Chance pins to help me manipulate this to get it to close enough where the Faribuff really just closes it down. You have to have that reduction like pretty close to being right on before you squeeze that Faribuff down. Now, in terms of the Jungbluth clamp, I think this is extremely helpful, not just for pubic symphysis disruptions, but for SI joint injuries, because you can really correct multiplanar deformity. You can correct anterior posterior translation, caudal cranial misdirections, and then you can close down the gap. Now, what I will say is that everybody gets tempted when they're first starting to just squeeze down the Jungbluth to close down the gap. Really, you have to have a sequence. And the sequence I like to use is first correct my craniocaudal correction by leaning on one side of that Jungbluth clamp, which lifts up the opposite side or pushes down that side, depending on which way you lean into it. Then I like to correct my anterior posterior uh, deformity. And then the last thing I'll do is close down that gap. And I do position some 3-2 wires out of the way of where my screws are going to be to kind of hold that reduction once I get it to where I want it to go. Now, the goose clamp is also extremely helpful for these reductions. Here's just an image that I had of the goose clamp. Either tine can be on the sacrum. In this case, I've got the curved end on this side. I routinely have it a little bit more anterior than what's shown in this image. And you'll just make a little and peel a little bit of the external oblique off, use your cob to dissect down. You may get, there are veins here that can bleed. Don't get alarmed by that. You can pack it and come back, then put your clamp in. But I also do like using the goose clamp for my SI joint reductions. It is important to realize where your L5 nerve root is. And one of the things is that, if you want to, and I don't like self-retaining retractors in this area, and I don't like malleting in Homans. And the reason is you're not quite sure where the L5 nerve root is. If you can see the SI joint clearly, which you should if you're doing an open approach, the more posterior you place your retractors, if you're going to put a Homan in and mallet it down, the more posterior you place it, the less likely you are to get into that L5 nerve root. And as you get more anterior, you just have to be cognizant that you're going to be closer to that L5 nerve root. Now, what about plate position? A lot of times we're fixing these with screws, but sometimes you can't get a screw in, or sometimes you want something to hold it before you put your plate in because your clamp's not quite doing the job. And it's, common for you to want to use a 3-hole or a 4-hole recon plate. You can see based on the position of the L5 nerve root, you can't really have 2 screws medial to the SI joint. At best, you're going to have 1 screw medial to the SI joint, just posterior to the promontory. That's going to be the safest spot. Now, on the ilium side, you can have 2 screws lateral to it, or even 3 if you wanted to. But really, your limited fixation is going to be in your sacral ala. Anything, guys, based on your experience on that?
You want to plan ahead for, where your iliosacral screws are going to go and try to put the plate peripheral to that.
And in terms of fixation, I've had one case where there was no room for iliosacral screws. Very small corridors.
Oh,
And I would say that one plate is not suffice in in that kind of situation. I was even concerned about 2. I ended up doing 2 plates back there to hold it. I don't really do a spanning dorsal plate. I know some folks do, and that's an option. Um, but just be cognizant that one plate is not going to hold this reduction. You have to supplement it with at least an iliosacral style screw. Would you guys agree with that?
I mean, half the time the clamp or the plate doesn't last as long as it takes to put the screw in, let alone to have the patient definitively fixed with it. So,
Yeah.
by the time a screw goes in half an hour later, you can see it loosening already.
Yeah. So here's just ideally where you would position that plate. Now let's go back to that case we were talking about. So in this case, I was fairly confident that I could get the anterior reduction right. But as Mark mentioned, if the posterior is not dead on when you fix the front, then your front's not dead on. So you can see here, I didn't fix the front. I just open reduced the front. And if there's any sort of comminution anteriorly, like it's really hard. It's really hard to get that right. And I would say that, admittingly, when I first started, I knew if I fixed the front, I was trained if I fixed the front, then the back would follow. And so I was not comfortable opening up the back as much as I think I wanted to be. So I was pushing fixing the front first to help me with the back. And there was a case where I spent a significant amount of time fixing that front and used orthogonal plates because by the time I was done with it, it turned into like multiple pieces. And guess what? I didn't have that front right. And it made getting that back right, this was a sacral fracture in that case, impossible to the point where I had to go back to the front, take some of my hardware off, kind of have a much more malleable anterior fixation hardware to help me with getting a reduction in the back. The other reason I pulled this case is you can see that I had screws in for a Faribuff clamp, but clearly I didn't have the right vector to help me with this reduction. And so I boarded using the Faribuff because it wasn't going to work in this scenario, especially where I placed my screws. And I went over to the goose, then placed the goose on. That helped with the reduction. You can still see that it's gapped. It's not perfect. And then I went ahead and placed partially threaded screws to get my reduction. Now, one of the reasons this is a good case, and I had a really hard time with this open reduction, as you could tell, is that there was a bridging osteophyte that broke. Okay. So my read of that SI joint was not as clean as a read when you don't have these bridging osteophytes. And so you have to be really cognizant if you got these bridging osteophytes, they can block that reduction. Uh, you can't see the reduction as well. And just be cognizant, know that it's going to be a little bit more challenging than compared to this contralateral side where you don't have that situation. Now you also see that I used two partially threaded screws at different levels. I just wanted to compress everything. I went back and forth between the two screws when I was tightening, and then anteriorly, once my back was right, anteriorly I just placed the retrograde Rami screw. Now, just some questions for John and Mark here in terms of, is two screws enough? Is one screw enough? Does it matter if you use what you use in the front? Um, let's say in this case, the front I hadn't fixed with the screw and I had an X fix. If you have an X fix in the front, can you just have one screw in the back?
Only one?
Yeah.
Maybe. Uh, so I would, yeah, I don't, John, why don't you go ahead, John?
No, I like the answer because I just think I mean I don't think we ever know, right? There's so many different factors
Right.
of what's going to be at play, right? What's the patient size or bone quality? Injuries like this are very unstable, and so often one point of fixation isn't adequate, no
Right.
matter what you do anteriorly, whether you have plate and screws, just a screw like you said. But I think a lot of times we do know that multiple points at multiple levels are going to provide more fixation, and so I think I'm very leery of just having any one point of fixation almost for any injury posteriorly and always looking to try to supplement some way.
Right.
Yeah,
But
I'm gonna present a pretty strong view on this. If you have a complete SI joint injury and you place an X fix in the front, there's really very little rotational control, and I've seen way too many fail where they've only had one screw in the back, and sometimes those are iliosacral screws and not even transsacral screws. And so you're asking that screw a lot, and those screws will acutely just back out. So I would say if you treat a complete sacral injury with the frame in the front, do yourself a favor and try to have at least 2 points of fixation posteriorly. Now, if you have transsacral style screws, that's going to be better than an iliosacral style screw. Again, obesity matters, bone quality matters, but I think having a plate in the front, let's say it's a symphysis disruption, having a plate in the front gives you a lot of rotational and torsional control compared to an X fix. But you still need to put fixation in the back. So I would not take shortcuts and just put one screw in the back.
yeah,
Agreed.
totally agree. I don't know about you guys, but a general rule of thumb that you have followed is if I think they need one screw, they get two. If I think they need two, they get three. And if they think they probably don't need a screw, they're probably going to get one.
Yeah, I think that's a whole nother, big topic in terms
A
of how
little
much
philosophical.
fixation to put in the back. I was very aggressive with putting a ton of screws in the back early on. And the younger patients have kind of backed off because I think there may be issues that we may potentially could be causing at that SI joint in really young patients by putting multiple screws in the back. Now, if they need it, they got vertically unstable pelvis, everything's totally off, multiplanar deformity, then you got to do what you got to do and add as much fixation to keep it there. But some of these more benign injuries, I wouldn't be as aggressive, and I think we'd all agree with that. Now, um, just for the sake of time, weight bearing in this patient who's not an elderly, what are you guys' thoughts?
Yeah,
I'd have weight
yeah,
bearing on the right and then toe touch or touchdown on the left for 6 weeks.
Okay.
same.
I do the same thing and then start partial progressive. Okay, great. Now let's move on to Dr. Adams' talk.
All right, so let's get started. So here's the situation. We have bilateral injury, and both require an open reduction for fixation. So both sides require an open reduction. And so the question is, for the approach now, do we choose midline or bilateral paramedian approaches? And what's at stake, what we're trying to avoid, the concerns are skin necrosis in between those two paramedian incisions, as well as a deep infection. And so when I'm done with this talk, what I'd like you to be able to describe is the angiosomes of the posterior pelvis. What am we talking about with that? What a bipedical flap is and how it works, as well as how it's created safely. I also want you to be able to describe how to take that information as well as other relevant factors to choose an approach. So we're all familiar with this vascular anatomy about the pelvis, and I would like you to focus on the superior gluteal coming around the notch. And what we talk about a lot less is that angiosome concept. And so an angiosome is an area of three-dimensional tissue that's perfused by a source artery. So in this case, the source artery is that superior gluteal, which goes to the maximus and the medius. And then there are perforators that finally reach the skin superficially. The perforators come through the muscle and through the intermuscular septum to the skin. And then at the skin, the superior gluteal covers this area in blue, and the lateral sacral artery covers the area that's in green. And so these are the two source arteries that perfuse the relevant area for the two approaches we're talking about. And so two paramedian approaches that would, if they connect subcutaneously in the middle, then that would disconnect the perforators completely from the lateral sacral source artery and a substantial proportion of the contribution from the superior gluteal artery. And that's worrisome. And so, in addition, you have to keep in mind a midline approach also would elevate past that lateral sacral territory, which would eliminate blood flow to the skin, to the green area from that lateral sacral source artery. And so I think this bipedical flap can teach us how and why the skin can remain perfused after a source artery gets disconnected from its cutaneous vascular territory. So a bipedical flap has two vascular pedicles with dual perfusion, both distally and proximally. And here's an example. There's a traumatic wound over the anterior tibia. Two incisions are made on the leg, one lateral, one medial. Traumatic wound then in the middle gets to be closed tension-free, and the lateral and medial surgical wounds can get skin grafts. And now the blood supply comes in from proximal and distal in between the two incisions, and that can be successful. And the bipedical flap survives on what's called random pattern cutaneous blood flow. And so random pattern cutaneous blood flow is created through this network. By the time a source artery, such as the superior gluteal, reaches the skin surface, it creates perforators, each with distinct territories. The perforators are linked to other adjacent perforated areas by what they call direct means and indirect means. And so these linking vessels are the direct means of linking one perforated area to the next perforated area. And then the subdermal plexus is what they refer to as the indirect method of communication and blood flow in between adjacent perforators. Okay, and so then all of that put together creates the random pattern cutaneous blood flow, which links the angiosomes together and allows perfusion of the skin that has been disconnected from its muscular perforators. And so to create a well-perfused flap, the general rule of thumb is that the ratio be 3 to 1 or less, with the 3 representing the incision length and the 1 representing the width of the flap. And so to make this a little bit more obvious, what we're talking about, let's apply the ratio here. And so this is what a 3 to 1 ratio would look like. Okay, so if the flap was narrower or longer, that's no good. The skin in the middle of the flap would not be able to be perfused by the random pattern cutaneous blood flow. But there are some necessary prerequisites. Okay, you can't just do this on anyone and have success. So contused skin, degloving, those would be negative predictive factors. Linking vessels, subdermal plexus have been injured, and those can't be relied upon. Other things that would be negative predictive factors would be peripheral vascular disease, smoking, diabetes, and then perhaps issues related to the trauma that the patient had experienced. So now that we've kind of looked at it from the perspective of the skin, what are the other relevant factors? Well, there's the fracture location. So we've got, on the left, we've got these crescent fractures. On the right, we've got bilateral sacral fractures. So bilateral crescent fractures, that would push you towards a bilateral paramedian approach, because those injuries are too lateral to access through a midline. And then bilateral sacral fractures would push you towards the midline, would make some more sense perhaps for a midline. And then the implants matter too, right? So lumbopelvic implants have traditionally been applied through a midline, but the tension band plate that Reza alluded to before, that's typically been done through through paramedians, and posterior iliac plating as well. And so, in summary, we reviewed the relationships between the lateral sacral and superior gluteal to the posterior approaches to the pelvis in terms of those angiosomes. That bipedicle flap, it relies on random pattern cutaneous blood flow. Ideally, if 2 paramedian incisions are performed and the skin and the patient are healthy, the length to width ratio would be 3 to 1 or less. The injury location and the necessary implants also would play a role in that decision-making process. So those are some of those references. Thanks.
Mark, that was great. A question I have for you is,
Oh.
I don't think I've ever done a case that I open posteriorly where I'm like, the skin is in good condition. And
Right.
because it's usually bad enough and it's displaced enough and
Yeah.
it's degloved. And a lot of times they've also gone embolization, which is, another key factor here. So would you say that the safer bet is really try to avoid the bilateral paramedians at all costs? And what's your thoughts on that?
Yeah, it's proceed with caution would be, I think, the message, that it's not unreasonable, completely unreasonable, that there is a somewhat of a pathway to success, but if you do it and the patient's skin dies, well, it's because that skin was basically mostly, say it's that young 32-year-old that you mentioned from before, right? They're healthy. They not smoker, no peripheral vascular disease, etc. It's just that that skin was so contused from the trauma that that microvasculature is not in capable of the random pattern cutaneous blood flow. And how do we, I don't know if there's a way of ever figuring that out, but I would be trying to figure a way to not do the two. I would try to figure it out. But if you had to do it, there does seem to be some support that it's possible.
And on that same note, if we're trying to minimize injury to the blood vessels, the supply of the skin through the muscle and the fascia, when you're doing these approaches, would you say to try to minimize um, causing more dead space, using your lap to sweep over the fascia and kind of try to get down to bone, and then work the muscle off the bone laterally, that being if you go straight midline, or even if you go paramedian, like really try to avoid causing increased dead space.
Certainly, and that's something that has always bothered me about the paramedian is the amount of dead space that we create in a medial direction. That you make the incision lateral to the uh, lateral to the PSIS, but then you're almost to midline subcutaneously, basically, to nicely elevate the maximus.
Yeah,
Um, and so that's the traditional approach, and that feature of it has been something that's always bothered me. There is a nice article by Julius Bishop, where instead of the classic teaching is to go medial and take the maximus completely within its fascia in a lateral direction. And what Julius wrote was they incise the fascia of the maximus and take the muscle itself and
yeah,
leave the fascia medially, which makes sense from an angiosome perspective, then that the perforators are coming up through the intramuscular septum at the edge of the maximus. So none of those have been disturbed with the method that they described. And they had a nice series of patients, quite a good number, and very, very minimal on the complication. So it seems to be working for them.
that's great. John, anything to add to that?
No, I was gonna say the same thing about that paper. And I think that technique of how you're doing that approach, I think's evolved over time. I mean, the kind of the very worrisome rates of infection and necrosis early on were kind of negated by that. So I think it probably opened up the possibility for some of these bad soft tissue envelopes that you're mentioning, that if you do it well, you have that good planar dissection, you don't undermine, it preserves the blood supply, and you don't get into those same problems. So I think again, attention to that approach and the technique is very important.
Yeah, and the other thing is now, as you guys go on and you take your first jobs, you may be at centers where if you need lumbopelvic fixation, the spine surgeon's not familiar with doing percutaneous lumbopelvic fixation. And that's made a huge change in my practice with just adjunct fixation and being able to do it percutaneously and not open. I think there's a significant difference between the complication rates of an open lumbopelvic versus percutaneous lumbopelvic. And I would just urge you to ask some of your spine colleagues if they don't do percutaneous lumbopelvic to really try to pick up that skill set because it makes a huge difference in regards to complications. Okay, John, let's go on to your section.
Let's see if this works. Oh boy. How's that looking, Reza?
You're good, man.
All right, so we'll kind of switch modes and go to sacral fracture reduction techniques, but also no relevant financial disclosures to make. And just some objectives again. I think the concept we're here talking about open reduction, but I think one of the things is just understanding when you have to do it. And I think that'll be pretty cut and dry. But then we'll cover some common reduction techniques and then hopefully spend some time just delineating some of the kind of nuances of sequencing of reduction, fixation, and different modes of how you can go back and forth and what you should look out for. And so I think we'll just go through a heavy case based, try to get through 4 cases relatively efficiently. But First one just from about 2 months ago, 32-year-old healthy motorcycle. He has this pelvic ring. Not a whole lot of information to show you, but you can see a complete symphyseal disruption. And this right-sided sacral fracture that you see is displaced, translated anteriorly, and a little bit of caudal displacement. He's not a dysmorph. He has a viable S1 pathway to accommodate any screw you want to place. And so the displacement is shown here nicely, I think, on the 3D renderings. You can see it. And then when this came in, I think a lot of times people are thinking about, should I do an open approach? Is there a lot of comminution that would preclude an open approach and for that reduction? And so there was a lot of interest for some people, especially fellows that were like, this is the one. I mean, it's a healthy patient, skin is good. Let's think about doing an open approach for this. And it was kind of just, hold on, let's just go back to the basics. And so if we do an open approach, I think we nicely talked about this. That's a simple symphyseal disruption that can be reduced, relatively straightforward. You can see there, definitive plate. And I think, again, a relatively routine 3.5 millimeter reconstruction plate is going to be a probably common choice for many people. And I think we'll show through examples that it doesn't preclude you from even getting more reduction and still mobility, but it secures your anterior reduction, secures your anterior hinge, like Reza alluded to allow for a stable hinge to maybe help your posterior reduction by giving you some sort of stability to kind of work from. And so for this patient, that reduction and that fixation, you can kind of see that posterior reduction is much improved. And so some intraoperative advanced imaging, you can see there that indirection or indirect reduction of the front yields that posterior reduction. And so all planes, they look just about the same. And so that just goes ahead and gets compressive reduction with initial transsacral screw in a caudal anterior position that's partially threaded, as you see, and then a second screw, as we discussed, just for more stability. But again, an indirect reduction for a pretty displaced injury. I think it's there. And so just because something's displaced doesn't mean you can't still do indirect reduction, closed management, if you will. And so I think just don't forget about it. There are going to be displaced injuries that do, maybe fortuitous or from other indirect means, you can get still adequate. And so just don't completely write it off.
John, you brought up a really good point, and that 3D rendering I think is extremely useful. Um, because you are going to get tempted to open reduce some of these. And I think if you are thinking of open reducing it, if you have significant dorsal comminution and it wasn't really a tension-based injury at the back of at the posterior aspect of the sacrum, those reductions can be extremely challenging. If you got significant comminution throughout there, your confidence level will quickly go down in terms of like, did I make the right move opening it? So I'd be interested to see what you guys think. If you have a situation where the reduction you think is pretty close, but there's significant comminution, are you more likely to keep using your closed means of trying to get that as close as you can? Or are you still thinking, I'm going to open it?
Yeah,
Yeah, what do you think?
absolutely the former. Yeah.
So if you see a lot of comminution, you're very hesitant and you'll do what you can close to try to get that as close as you can. Is that what I'm hearing?
For sure for me. Yep.
Okay. John, how about you?
Yeah, it definitely is. I mean, I think it's very akin to a femoral neck. I think there's a lot of talk of open versus closed, but I mean, if there's comminution, doing the approach isn't going to help you in any way, and it just probably adds more risk, more time, and more everything without any benefit. And so, I think I agree with you guys. I would
Yeah,
opt away from it if there's significant comminution.
yeah. Great.
With the percutaneous versus the open for everything in the pelvis, I think we have to work backwards from the stability and the reduction. And so if you can get the same reduction in stability percutaneously, then that's a clear advantage to opening it.
Great.
And so let's move on to this. Patient two, a little bit older patient of mine, but I think shows up a good point. He's 61, motorcycle. He's a big boy. He's unstable. We're not going to cover that. He gets appropriate care early. But here's his pelvic ring. You kind of see it. Again, some very select cuts. I don't give you guys a whole lot, but here you can see kind of a zone one, maybe gets into be zone two. Sacral fracture. You see that top left, there is disruption of his L5S1 facet. and all that that matters. But again, he's a little bit of a dysmorph, but big pathways, maybe just different obliquities, but his S2 is also viable for a transsacral screw for fixation options. Again, very limited. Here's just the 3Ds from an anterior and a posterior. And so, again, we've kind of hit home. It'll be a common theme, but he had a reconstructible front. And so that got an open anterior approach, even though he was obese. And that gave us a little bit of an indirect reduction. But then it didn't go like our previous patient. You can still see displacement even without advanced imaging. And so then it's thinking about how am I going to do that from an open posterior approach? Everything Mark talked about comes in, but it's a unilateral injury now. And so we're also thinking in conjunction with our spine colleagues for, I think, a number of factors for adding spinal pelvic. But here, just a couple different type of reduction techniques straight off the AO website. But anything from any sort of reduction clamp, and I think Reza showed some, but large or medium pointed tenaculums, any sort of the modified pelvic reduction clamps, the goose clamp, any other angle clamp can also be, depending on the vector. And then I think some of those ones in the middle, Shan's pins, like Reza mentioned, but now we're prone. And so going from the PSIS or the PIIS going towards the anterior inferior iliac spine, that's a great corridor. And you can do that with Shan's pins. You can do that with screw clamps or screw assisted clamps and just a lot of potential different options by themselves or in conjunction with one another. And so for this patient, I think a very straightforward. There was a clamp dedicated for the facet disruption, for that little bit of cranial reduction needed, and then more of the typical coronal plane or medial to lateral reduction with just a large point reduction clamp. You can see there, just on the sacrum, typically right next to the spinous process, and then somewhere in the good bone that you're going to have fixation. And so I think just nicely illustrates that clamp application that you see. And then here's just a point I wanted to show, because I think a lot of times we think about doing percutaneous screw fixation, but then the sequencing depends on a lot of things. And so, he has pathways like we've shown. He had iliosacral S1 and transsacral S2, but oftentimes we're going to try to lean towards getting iliosacral screws first, because once you put in that transsacral screw, as you see there, it's going to cover up your indentations, which I think are critical for fluoroscopic evaluation of your safe implant placement. And so here, though, it's necessary. You see, even with an anterior reduction and a posterior reduction, there's still kind of anterior gapping on the sacrum. And so that needed more anterior reduction vector of the screw versus the typical posterior to anterior iliosacral screw based upon his pathways. And so here that S2 transsacral screw goes in. And so I think it takes time and noticing where that screw is, what your pathways, what your imaging are, because once that screw goes in, then you're still gonna have to place your iliosacral S1, and just having those images in place will just allow you to place a safe S1 implant. Any thoughts on that, you guys?
Yeah, so that's a really good point in regards to the S2 screw. If you're going to put that in and you're going to not be able to see your sacroiliac indentation at S1, I
Yeah.
think that's critical and really important. John, so let me see if I got this straight. So you used, even though it's a longer recon plate anteriorly, you used a flexible implant to fix the symphysis, knowing that you're going to manipulate the posterior aspect of the ring.
Yeah.
So the worst thing you could possibly do in the front is to put a stiff, pre-contoured symphysis plate and add an orthogonal plate to that. I'd say that's probably the worst case scenario. That's going to really lock up what you're going to do in the back. I will say that for reductions where the back is not that far off, and I think I can get it perk, I have gone to stouter plates for the symphysis just because, as we all know, the implants can break in the front or screws can back out. I've had obviously a lot less implants break with the stouter implants. But in this scenario, I would use something flexible like this because you need the flexibility.
Yeah,
Um,
I couldn't agree more. I mean, I think that it's kind of the sweet spot, right? I mean, it's going to provide enough stability to hold that torsional multiplanar instability, but it's going to still give you the flexibility to still manipulate in quite a bit. I think we'll see in the next example. It doesn't preclude you from doing probably a lot of reductions sometimes. And so I think it can only help you, assuming you get that correct, or at least pretty darn close, like Mark was talking about.
And then in this case, you astutely brought up, the L5S1 involvement, and we don't know to what degree that involvement matters down the line. It depends how much of an involvement there is. I will say one of the hardest sacral fractures I had to reduce was one where initially I didn't recognize that the L5S1 facet joint was dislocated. And I just couldn't move that sacral fracture whatsoever till I realized that there was a dislocation of the L5S1 facet. Once we reduced the L5S1 facet, then the sacral fracture was a lot easier to reduce. So really be cognizant when you're looking at these, especially in zone 2. Look at the involvement of that L5S1 facet joint, because you'll be surprised how much that matters, especially if it's dislocated.
Absolutely. And so, in this series, that the fracture was reduced as us, and then our fixation went first. We can talk about that. But then the spinal pelvic was added again to bolster the instability of that injury. I think Mark brought up a good point when we were talking about this beforehand in terms of that location of the sacral fracture. It's still lateral, and so there's still some significant vertical instability, especially with those more displaced patterns. And so again, there wasn't any reduction done with the spine instrumentation. It was purely as kind of a neutralization of still residual instability after the reduction was already performed.
And John, would you have added that lumbopelvic? I mean, that looks like you got good fixation, but would you have added that if this was a non-obese patient, or is this your indication was because he was so big?
No, I think it was everything. I mean, I think it was displacement, it was obesity. He was 61. And so I think all those together with his instability in the facet, I think those are just kind of like three strikes in the negative column. And just, I don't think that's a lot of fixation, frankly. For that, for all those things, I think those 2 points is pretty lean, actually.
And is the lumbopelvic in this scenario with a symphysis disruption letting you have the patient weight bear earlier, or does that not change your weight bearing management for this patient?
No, 100%. They're fully weight bearing bilateral.
Good.
Patient 3, similar but different. I mean, here's another guy younger, but still obese. You can see his soft tissue envelope motorcycle. He has that pelvic ring with symphyseal, and then kind of a zone 3 that you'll see in a second. He is surprisingly stable, except he's got some neurological changes to his left lower extremity. But again, very select cuts, just showing a direct midline displaced fracture. He is a dysmorph. He has displacement, and again, his L5S1 facet is involved. And again, you can see here just those cuts. And so I think maybe Mark and Reza, just in terms of what you see here, when you start thinking about these approaches, does that drive you to do an anterior or posterior approach? We've been kind of hitting home some concepts, but what do you guys think for that injury displayed? Where would you start?
Mark, if you want to go
Yeah,
first.
sure. Yeah, certainly start anteriorly. You have a lot, we have a lot more reduction options anteriorly than we do posteriorly. And so we can you can kind of get the ball a lot further down the field anteriorly before you have to go posteriorly, as opposed to the other way around, if that makes sense.
But Mark, man, we know these angiosomes. I mean, look at that posterior read, man. That thing, I mean, come on. That is the one. I want to do that right now, don't you?
Um, but once you say you reduce that in the back, right? The odds that that's perfectly reduced in the front, even with something that's perfectly clamped in the back, you're still going to have some residual instability, and so then you'll be in basically the reverse of what we just described. And we know that we can make we can the front of the ring is probably the more familiar area and the area where we have I'd say more reduction options. You showed right, like our reduction options are what you showed there. Several different pointed reduction clamps in the back, and as well as a screw-based clamp for the PSAS, as well as the universal distractor. That's like four things. Whereas we have a lot more, I would argue, in the front of the ring in terms of getting a reduction. And so I think that would be why I would start in the front. But then I would be anticipating an open reduction still in the back.
Yeah, and I completely agree with all those points. The other thing you have to think about is if you go to the back, your reeds are on the posterior aspect of the sacrum, and you're going to be compressing the most posterior aspect, and you're going to be potentially gapping the front even more. There's no hinge anteriorly. So that makes it really hard to do. So another argument for going from the front. The other thing is, I don't know about you guys, but rotation's a really hard thing to correct when you're prone and you're trying to get these right. The other thing that's really hard to correct is if there's anterior posterior translation of one hemipelvis versus the other side. That can be extremely challenging to get right. I think the Jungbuff clamp and the PSIS is one of the few instruments that you can really use to try to help you with that. Um, but if you fix the front and you get the front right, it's going to really help you with the back in multiple different ways.
Also, the back is the more critical area for weight bearing and everything. If you were to have more of a malreduction in one area versus the other, you'd rather have it in the front than in the back. And so something that helps facilitates you getting it right in the back, as you just brought up, that having some sort of a hinge in the front that helps you close down the back, because otherwise you're gonna have some sort of malreduction in the back that's going to be more than I think what you would have if with the sequence anterior first, posterior second.
Yeah, I like all those. I also think one other thing we talked about, like, doing the front first and having a flexible construct. Again, I think sometimes the implants we're going to use posteriorly, and again, for maybe some of the same parameters, any sort of spinal pelvic, if there's any residual malreduction or deformity left anteriorly, once you do a pretty strong posterior construct, you can't overcome that. Once you
Yeah.
have spinal pelvic or several points of posterior fixation, there's not going to be a whole lot of still rotational ability to overcome and maybe get that little bit of malreduction that was there. And so, again, I think some of those things, that concepts of summation of malreductions, it's more forgiving with that timing or the sequence of anterior first, relatively strong, but still flexible construct, and then you can still have posterior access and mobility. And so
Okay,
again, I
John.
think, go ahead.
Yeah, that's great. No, I was going to say we're getting close to the hour. We're allowed to go over, guys, and I think the speakers are happy going over. So if anybody wants to stay on, great. We'll kind of continue and go over one or two more cases.
Okay, a few minutes. We'll kind of speed through a little bit. But again, very similar sequence. We've covered this a little bit, but he got open reduction in the front, same construct you've seen. And then again, you can see through the images there, there's improvement, but the interval CT shows that's nowhere near acceptable. And so again, I think going through the same concept now of how are we going to do this prone, you still see the residual displacement. What options do we have? And so again, a lot of stuff to go through, but here's just one slide that demonstrates kind of a lot of concepts. I think Reza just talked about the young Bluth, and he showed in his anterior approach, it was a 3-5.
Yep.
But here, this is a 4-5 screw. And so again, a larger diameter of excursion, a lot more strength, and I think a very good option here. This is done through the PSIS, as you see there is a footprint just that was shown in that the figure. And so this is open. It can be done percutaneous. I think hopefully there's a paper coming soon that can talk about that. But again, it gets a lot of control directly on those display segments and allows that kind of multiplanar reduction that was demonstrated by Reza. But here again, the screws are there, and so a lot of concepts that come into play. You can see, maybe if you see my cursor, the drill for the S2 transsacral pathway is there, and this is the stable side. The contralateral side is where the zone of injury is, but that is there just to serve as a template for where we're going to be. It lets our spine colleagues kind of come in and put their iliac fixation and not impede our way of where we're going to put our S2 path. We can't plan that on the other side just because there's still displacement, and so we don't quite know where that's going to be. And so trying to stay ahead of the game and make sure we don't impede our pathway, because I think the S2 or pretty much any transsacral pathway is more demanding than that pathway from PSIS to AIS. I think they can angle their screws at any level a little more easily than we can to accommodate that pathway. And so I think it takes precedence in planning just to make sure that we don't block it. And then as we get that reduction, we can see that we're going to use all three modes of compression. Here we have the young booth still in place. We have compression through the spine instrumentation from side to side. And now that screw is going to be coming from the injured side through the pathway we already established. And we're going to have kind of three different modes of compression from posteriorly all the way through the center of the sacrum. And so I think all three modes get hit. And then we can talk about the reduction and fixation, I think was good. Post-op CT. And then at 6 months, he was doing well, besides his left foot, which didn't recover.
So one thing there with that young booth, just to make sure everybody knows, not only is that 4-5 screws, that's a 4-5 young booth. It's much larger than the 3-5 young booth, and the 3-5 young booth will not work. It doesn't have the excursion to be able to get from PSIS to PSIS, and most centers, don't routinely have that clamp around. So if you're going to do this procedure, make sure you plan for that and you get that clamp, because that's an extremely powerful clamp for this type of reduction.
Yeah, very good
Uh,
points.
John, do you want to talk about the indication for the lumbopelvic for this one as opposed to the previous case?
Yeah, Mark, what do you think? You brought this up. We were talking
Yeah.
beforehand. I think you said it very
Well,
nicely.
just say, so a big difference between this patient and the previous patient is that this is an S3, this is a zone 3 fracture rather. And so once the reduction's been achieved, now L5 and the L5 disc is trapping the displaced segment, and that's preventing cranial displacement. It's neutralizing those shear forces. As opposed to the previous patient where S2, that it's not contained and it's got the facet injury as well. And so that's a big difference between the two. But for this patient, the obesity, the limited pathways, I believe, that were present here, where you couldn't have sufficient iliosacral screw fixation, those are contributing factors to say, okay, we're going to neutralize this with the lumbopelvic is my understanding.
Yeah, I think so. I mean, just putting there, I mean, he has an S1 pathway, but really that pathway kind of ends at the midline. And so if you put an S1 iliosacral screw, there's not a possibility for an S1 transsacral screw. And so the S1 iliosacral screw is going to end in the midline, and you get probably 4 or 5 threads of fixation,
Right.
not adequate. And then S2 was only available for one, and so probably inadequate as well for total fixation for that amount of instability.
Right.
Okay, last case. Something different. Sacral fracture, but maybe not what we're thinking about for higher energy. This is an elderly patient. She's 76, was going up the bus one step and then kind of fell back, landed on her tailbone. And she has this pelvic ring, which I think we're more astute now in terms of determining. But she kind of fell through the cracks, didn't really get advanced imaging, and people didn't notice it until, 1 or 2 weeks where she was having pain. And now she was a previous, community ambulator, but that declined significantly. And so she showed up with this pelvic ring. You can see her left superior and inferior rami fractures, but then just very select cuts. She has bilateral sacral fractures with this S1 or top of S2 transverse component. But then again, an H or a Y type pattern that you can see with kind of extension down her left posterior sacrum, as well as that sagittal. You can see a pretty significant translational deformity as well. And so, I mean, this is probably a whole webinar in of itself, but Reza, any thoughts for this? I mean, again, there's paper supporting in situ for some of these injuries, reduction, how do you do it? Is this open? Is it closed? How do you start thinking about these?
Yeah, it's a really good question. And unfortunately, a lot of these are going missed out in the community. A lot of these are being treated non-operatively. I think a common mistake people make is that even if they order the CT scan, they're just looking at the axial views and they say, oh, that doesn't look bad. As I urge all our trainees, you got to look at the sagittal views. That's where you're going to pick up a lot of these. And this is challenging because there's not really kyphosis, there's translation. Now, if I was the patient, would I rather have translation? Well, if I have small degree of translation, yes, because if you have kyphosis, then your sagittal plane balance overall can be affected, and that can lead to its own problems. And doing
I
an
think
open,
lost his sound.
you can't hear me?
I got you.
You can hear me?
Yeah.
I can hear
Okay.
you.
So, do you decide to open reduce a 76-year-old from the back? That's a tough question. I would say that if they have significant kyphosis, and if it's relatively fresh within the first week, I think you can correct about 10 to 15 degrees just with positioning, prone, and I've got a slide of that if we have time for that. But that's not going to correct translation. And to do this open in the operating room with routine measures in regards to what was previously described using Shan's pins, I think that's extremely challenging to try to move that whole segment. Now, John and his group came up with a nice technique. I think this was a while back now, a couple years ago, and I'm sure you'll go over it. But using the lumbopelvic instrumentation is a great way of helping reduce translation. But you also have to be careful in regards to if you're going to do that component first, if the vertical fractures, that being the zone 2 fractures or the zone 1 fractures, if they're not adequately closed down, then those may go on to non-union. And so you really have to have a nice sequence and routine in regards to if you're going to open reduce these and use lumbopelvic fixation, and getting that sequence right. And I don't know, John, maybe you can discuss, can you do some of this percutaneously and not open it? Um, and what are some challenges with doing it either open or percutaneously trying to get this?
I mean, I think both. I mean, a lot of it goes into who you're working with. I'm not dual fellowship trained. I think very few people are. And for sure, very few people are doing a lot of these complex injuries every year. And so a lot of this, I think, goes on to our spine colleagues and who you're working with. And so we were fortunate to work with Eric Kleinberg, who's a good friend and a good colleague, both at Davis when I was there, and now he's here in Houston. But we kind of did this together. And so we just did a lot of these, and we just figured out that a lot of the reduction was him driving it with him placing screws. You're instrumenting all this beforehand. L5 for sure. S1 directly into the unstable sacral segment and then into the ilium. And so then really the amount of it was, again, placing good screws, and we'll come back to it, but more so the contour of that rod that's depicted there. And so the sequence that would come in would be here, right? So screws are placed, and then your rod for this pattern is kind of anchored distally, secured to the bolts. Then you can use spine instrumentation to distract, to make room for reduction. And then again, with spine instrumentation and tower pushing devices, they can bring either rod down to bone or bone to rod, whatever we're going to think about it. But that corrects your translation and even some of your kyphotic angulation if you have it. And then you can compress, again, all through spine instrumentation. And so that sequence is pretty darn reliable to drive some of these reductions. And then even more so, we can't really do any sort of our fixation yet, right? We can't place iliosacral, we can't trace transacral because there's no reduction, there's no pathways that are aligned. And so you're using that sequence, and then they just have to be good enough. You have to work with them enough to know that if they just keep their anatomy in mind, they stay high in their pedicle, still safe, still contained, but nicely depicted there. There's still going to be room for you to place, depending on their available pathways. You can still place an iliosacral or a transsacral screw that's shown here. And so, again, just the sequence that we showed, or the series we had, just you can drive pretty good reductions. And I'll show you the one we just got for the patient. But out of this series of patients, they took displacement over a centimeter down to a couple millimeters, and then a good change in their angulation. Again, all driven by how much you contour the rod. And sometimes it was right the first time, sometimes it comes off, recontoured, and it went through again. And so not typical, but I think a very good reduction technique. And that's what she got. Weight bearing is tolerated, just like we talked about. And there's her improved post-op. It's not perfect, but I think it was worth the open reduction. Again, your point of translation versus angulation, very important. But I think if just doing in situ fixation for that displacement on the left, I think that's asking for a lot. Probably not the best choice. And so I think a whole lot of details to cover, but I think just a good example of another reduction technique. So overall, there's too many injuries to talk about tonight. I think you always have to drive how much you think about the injury, how much do you understand every single thing that goes into play. Don't forget about closed reduction. They're still there. They're still possible with displaced fractures. But if and when needed, there's a lot of reduction techniques that can be helpful.
So last case, 29-year-old male jumper who fell from a significant height and has a relatively comminuted anterior ring like we talked about here, maybe something you wouldn't want to approach from the front first because getting that right is going to be challenging. With significant displacement. Here's some of the axial cuts. Here's the sagittal view. You can see the degree of displacement. A lot of that may be rotation, but there is significant anterior displacement occurring there. There is some comminution also posteriorly, so it's not going to be the easiest reduction. Guys, would you even try going after the front? The front's not very displaced compared to the back, or is this one where you'd say, you know what, maybe at most the frame in the front and I'll go try to fix the back? And if you are going to fix the back, what would you really approach?
For the front, I think there's a little bit too much comminution there at the right ramus for an open reduction for that to be satisfying and feel like you can hang your hat on that. Perhaps on the left, an open reduction, a nice clamp would help, but it does seem a little bit like a long run for a short slide. Um, there, you can the percutaneous methods that we do for ramus screws, you don't need to commit to the screw, but you could commit to a wire that gets across both, and that does sometimes help with alignment at the ramus fractures, which overall improves some of the pelvis position, hemipelvis position, which can help you with the back, similar to what we talked about before.
Yeah, John, anything to add to that?
No, keep going.
Okay. Now, I thought the front was going to be really challenging in regards to getting anatomic reduction. And it wasn't a wide open like pubic symphysis disruption where I needed an intact hinge. I thought things were relatively close to each other. So the decision was to go from the back first. And you've got this, you got the horizontal component, the zone 2 sacral fractures, and then you get the transverse component that's around S3. He's young, and so we decided to go and fix both. And really, the reads were not that great for the vertical component of the sacral fracture. And I thought if I got the transverse component right, I could use some of the reads off of that to see what the most caudal aspect looked like. And so to get that translation fixed, placed a point-to-point reduction clamp on just the anterior aspect of the sacrum distally and brought the other tine towards the spinous process. Had the cob underneath to also help with that on the contralateral side. And here's what it looked like in the operating room. So this tine slips anteriorly. We've gotten that reduction that we want. This is a mini fragment, 2-7 plate, just holding that reduction. We still have the comminuted vertical sacral fracture on the other side. Don't want to fix this side's transverse component quite yet because that's probably that's going to go right where my sacral fracture is in regards to where that plate is. So then utilize the large Jungbooth clamp to correct some of that anterior translation. There's some comminution here, which makes that challenging, but got that to the point where I was pretty close. Then place the guide wire and place the screw through the vertical component. That's just an image showing the large Jungbooth clamp and the clamp setup. Placed the screw across at S1 iliosacral. Now I had that clamp, so I didn't use a partially threaded screw. And there was quite a bit of comminution. And in the chat, Dr. Wojon from Minnesota mentioned, you talk to the patients beforehand about possible postoperative nerve injury when it didn't exist pre-op in a setting of comminuted sacral fractures where you're going to open from the back. And I would say that absolutely we do. It's something that, the nerves are probably already partially injured, if not completely injured during the initial injury, and we go in there and we manipulate things and they could be further injured. So, I don't know about you guys, but, try to talk to the patients. A lot of times it's the patient's families because they're intubated about potential worsening of neurologic injury with just the manipulation and the surgery. The bigger question is, you guys use partially threaded screws and really try to compress when there's significant comminution and you got it open or not? And how do you decide?
Yeah. Yeah, so I'm quite worried about the same thing, and talk to people about it. But my understanding is that there isn't necessarily data to support my worry that about
Yeah.
compressing the nerves and so forth. That's my understanding on that.
I think even though there's no data, we got to be really careful. Like if you're looking at you, sometimes you can't even see this framing, right? But if you're looking at the framing and you're compressing and that framing is
Yeah.
getting smaller and smaller, then you got to back off. If you got any reads anteriorly, let's say you got an oblique fracture of the rami anteriorly, if you start seeing shortening of that, you got to like back off. So you can't just keep tightening. You got to look for clues where you're causing some deformity. Um, I don't routinely use nerve monitoring. What are your thoughts, guys, for something like this? Um, I just don't know what to do with it, and I
Know
can't
what to do with
stop
the
operating
information.
in the middle of the surgery.
Right. Wouldn't know what to do with the information.
Okay.
Yeah, I mean, some of the times during those stuff, especially when you're using spinal pelvic, our spine surgeons, they often use that as part of their protocol. And so we've often had that exact situation happen and we don't know what to do with it. We've had a reduction occur, even and a signal drops and a spin is the fracture is reduced. And so it's not like the nerve is entrapped in the fracture. And so are you going to take it down and try to undo it? Or is it just kind of the neuropraxic manipulation that somehow there's a second hit or some phenomenon that the nerve was sensitive to? And so again, I'm not sure what to do with the information. I just it doesn't change what you're going to do, and all the implants are safe, and so I don't think it adds to it. So don't routinely use it at all. Or the information I do get from when we've have it, it's not very helpful.
Great. So
What?
here, the vertical as well as the transverse component was fixed. Then we fixed the transverse component on the other side and then added lumbopelvic. You'll notice that the spine instrumentation goes pretty cranial because there was a L2 burst cranially. And then here, he had a little extra padding. So I asked my spinopelvic spine colleagues to actually extend the rods down because the transverse component's somewhere in here. And I thought the second the guy starts sitting up, he's going to deform these plates. So these, in a way, are potentially protecting that area a little bit. Um, had an X-fix in the front anteriorly. This is his post-operative CT scan. In regards to the reduction, here's his 3-month follow-up. At 8 weeks, the frame came off, and he's ambulating. Now, he doesn't have bowel and bladder control, which he's never had. I don't know if that's going to improve at the 3-month part. You could make an argument why you even fix that transverse component based on the initial injury pattern, but I think in a young patient, I think it's worthwhile. Um, and that's it for that case. I just wanted to look at any other comments on that case, guys?
No.
Okay.
No, maybe just to hit home, Reza, there's a question from Michael Allen just talking about femoral decompression, and you mentioned it for this case, they
Yeah.
decompressed, and so maybe just a quick blurb to answer that and address that question. What do you think?
Yeah, so in this case, there was a piece of bone that was in the foramen. So, we're there, it's open. The nerve was actually transected when we got in there. So, I think if there's something there to decompress, then go ahead and decompress it. In the elderly patients, when they get significant kyphosis with these insufficiency fractures that move, I think in those cases, if they're symptomatic, you got to do some sort of decompression. Um, but there's no clear-cut answer in regards to when you decompress or not. If they're symptomatic and there's something there to cause the symptom, then I think you have to do it. But I wouldn't just routinely prophylactically do it because you've done an open reduction.
I like it.
Okay. So any other questions? We'll leave that last case off for now. The one point in terms of the last case, we really focused on anterior open reductions of the SI joint. It's extremely rare for me, and I'd be interested for you guys. Are you ever doing posterior reductions of the SI joint? For me, there's only one real indication, and that's if my anterior reed is affected. there's a combo injury where there's a sacral fracture where I don't have a good read anteriorly, then I'll go look at the inferior facet posteriorly of that SI joint and open reduce through back there. Any clues for you guys of when you do an open SI joint reduction from the back?
Basically, if the supine approach, would be compromised for some reason, then we know it's available.
And this is just the clamp position in regards to if you're going in from the back, it's really finger palpation to feel the SI joint anteriorly, slide your clamp up around the front and get it around the back to help you squeeze that in the SI joint and then neutralize it with a screw across. And this was Mark's case. And John and I were really impressed that he had a patient with 9-year follow-up, but Mark's patients like coming back and seeing him. All right. Well, thanks everyone. If you guys have any questions, don't hesitate to reach out to either Mark, John, or I. Really appreciate it and I hope you learned some key points tonight.